You know, we often have conversations about parenthood in such, general ways, and everyone says, "Oh no, it's a great experience. This is when I had my child. My child is this old now." But
Yeah.
for other people, the conversation isn't that easy. Simply because once they've made a decision that they want to have children, the actual part of having the child can't be that easy. A lot of people do struggle with infertility.
Yeah, and once they do have a child, after that struggle, it's the transition that sometimes we might ignore, the fact that we have been going through this battle and there have been these baggages of the emotional toll, but also the expectations from society as a whole. How do we transition from that as well once we do have a child so that we raise them in a very healthy way?
Absolutely. We're unpacking this conversation this morning with Dr. Esther Olusola, gynecologist and obstetrician, as well as Siphesihle Dlamini, who is a clinical psychologist. Thank you to both of you for joining us. I'll start with you, Dr. Esther Olusola. I think we've had a few conversations here on the show about what infertility actually is, but for those who might be joining us for the first time, could you give us a brief overview of infertility?
Okay, so thank you for allowing me to join you on the show. So infertility is the inability of conceiving after 12 months of regular unprotected sexual intercourse. So it generally affects about 10 couples or more. We're starting to see that there's an increase even in male factor infertility that's also affecting couples. And then how we manage these patients all is dependent on how old they are. So we try as much as we can to first give them that opportunity to try conceive for at least 12 months. If you're above the age of 35, we give you 6 months. If you are above the age of 40, we try and treat you immediately just to avoid any other complications later on.
I mean, in that conversation, Dr. Esther, what are the key considerations when making that jump? What are you concerned about as the doctor in making sure that the right decisions are being made as you start off that journey?
Okay, so from our side, initially we want to assess the couple because it is a couple that we're dealing with. It takes two people to be able to conceive and to fall pregnant. So ideally, we want to have both the man and the woman present at the consultation, just so that you can also explain that either of them can be having a problem. Generally, with infertility, we say 33% of the time, it could be the male that actually has a problem. The other 33% of the time, it can be the woman having a problem. And the other 33% of the time, both of them could actually have an issue that might need to be treated. And then the 1% is that we can't explain it whatsoever. So we try and see, because specifically in women, the older that women get, the number of eggs that they have start to decrease. So the first decrease is slight at the age of 30. Then there's another decrease of the eggs at the age of 35. And at the age of 40 and above, there's both a decrease in the quality and the quantity of eggs that they have. So there we don't want to waste any time just to ensure that we actually have a very good outcome in terms of treating the patients. So we take those factors into consideration. The other factors we take into consideration is if women are known already with certain conditions, whether they have fibroids, whether they've had a history of miscarriages or not, whether they've never been able to conceive, or if they are known with hormonal imbalances or any other condition that we can actually treat that might be a direct cause to their current infertility.
In your experience, Dr. Olusola, how long does it usually take for couples to start seeking help and thinking about the infertility conversation when they've been trying to have children?
Unfortunately, it's quite long. You find that a lot of women wait until the age of 40, 42, and by that time, unfortunately, they don't have enough eggs as well. And we do have to end up referring them from the public sector into for assisted reproductive techniques. So we are finding that a lot of women, unfortunately, are waiting more than 10, 15 years. Sometimes they give up or they have a conversation with someone, then it finally sparks that interest. Okay, I do actually still want to have a child. So we have that on two aspects, or you find that some women have been trying for at least 5 to 8 years before they eventually seek medical attention.
Mm-hmm. Let's bring in Siphesihle Dlamini, clinical psychologist, on this one. Siphesihle, thank you for joining us as well. Let's talk a little bit about, do you deal with couples that are struggling with infertility, and what have you seen as an overarching issue here, and the difficulty to work together as a couple, as Dr. Esther was saying earlier on, that this is a couple's journey?
Thank you for having me, Benjamin. Yes, I do see couples with regards to infertility on their journey to infertility. And what I've noticed is the biggest issue is the fact that only one party is the one that's seeking help, is the one that is going for the medical checkups to find out what is wrong with them in their challenge with fertility. And it's mostly the women going to their gynaes for medical checkups, finding out what's wrong.
I was about to say that we guys,
exactly.
we always kind of subvert it to, or just push it aside to being a woman problem, and we are not part of it. And maybe that's sometimes a big conversation amongst our scenarios, that men do not get enough checkups and they don't feel responsible, right?
Yes. And so usually my starting point is to also refer the men to a urologist. I think Dr. Olusola will correct me if the urologist is the right doctor for the men, so that they also get a checkup, because I'm trying to alleviate the burden lying on one party in the couple, as opposed to this being a shared responsibility between the two parties. So it would be the woman is already going to the gynae in most cases, in all the cases, but in most cases the man is accompanying the woman to the gynae appointments, and they're not going to their own checkups to they are also okay, and that they're not part of the challenge in having babies.
And how does that affect the relationship dynamic, especially once they start undergoing the treatment process of infertility? Is there blame or shame that is associated that's within the couple that may cause strain between the two of them?
In the beginning, Palesa, it's usually that unfortunately people are not well informed. So most cases, the women or the men don't even know that they were supposed to check both parties. So there is a layer of not knowing. So they in the beginning, it's just we want a baby, but not knowing where to fully go to access the help, to fully get a proper analysis on what the problem is. And then we should be going to actually get a proper assessment. It's usually not no blaming or pointing fingers to say you are the problem. It now becomes a shared responsibility to say, okay, at least now we understand what the problem is. So now we know what to do with regards to actually fixing and going about getting a resolution for our infertility journey.
Yeah, I want to come back to you, Doctor. A very powerful point that was brought there by Siphesihle. Dr. Esther, where do men go for infertility issues? Could you clarify that for us before we go to a break?
So usually they do, like she rightly said, the men do accompany the woman. So depending on the institution that they do present with, a lot of reproductive medicine gynecologists, they do have within their practice a urologist, or if it is a male gynecologist, then they do start off, or even us as gynecologists, we start off with the workup for the men up to a certain point, and then we refer them to a urologist.
All right, fantastic. We'll continue the conversation. We're joined by Dr. Esther Olusola, a gynecologist and obstetrician. We're also joined by Siphesihle Dlamini, a clinical psychologist, on the line. We're speaking about the journey of infertility. How is that process? But also, once you become a parent, how do you overcome the challenges of that journey to that point? Is there work to be done even post that? It's 20 minutes past 11 o'clock Central African time. We'll speak to those talking points after the break.
Vue d'Afrique avec Joël Mouteba.
Cette peur d'un point de non-retour nucléaire suffit-elle selon vous à légitimer une telle offensive, Monsieur Talati?
Absolument pas du tout. Cela fait plus de 30 ans que l'Israël crie haut et fort sur les toits, où il veut se faire entendre que l'Iran serait à 1 an pour obtenir l'arme nucléaire. Parfois, l'Iran serait à 6 mois, parfois l'Iran serait à 2 semaines pour obtenir son arme nucléaire. Et curieusement, jusqu'à ce jour, il n'y a toujours aucune preuve que l'Iran a obtenu cette arme nucléaire en dépit des déclarations d'Israël et de certaines puissances parfois.
Vue d'Afrique, du lundi au vendredi de 15h à 16h, temps universel.
9 to 12 midday, Central African Time.
On the move with Palesa and Benjamin Moshatama.
All right, we're moving into this conversation and continuing it. It's a very sensitive one, but one that needs to be had in families, especially amongst couples. The journey of infertility. We talk about what parents go through during this period, the emotional highs and lows, the coping strategies that work, but also the ways to embrace parenthood fully after years of waiting. Dr. Esther, it must be different for different couples, so it's the length of time you can't really estimate it, but once you've seen a problem and you're working through the process, what is that process actually called?
So it's a bit different in terms of there are many different ways in terms of how we manage the patient in the process of them getting to being able to fall pregnant, etc. So after we do the investigations on these women, after we do a lot of counseling, etc., we identify the cause, then we give them certain treatments depending on what we have found from the history and the examination. So it's just a whole long process, or it can sometimes be a long process. And if we are unable to manage it in the rooms, then we do offer the patients then assisted reproductive techniques. So this is when what most people know as IVF, in vitro fertilization, or the other modalities that are used in terms of us assisting them then into fall pregnant.
So let's go into some of, the things that couple will have to navigate. Obviously, it's not an easy process, but it might not be a quick process either. Depending on what kind of treatment is necessary for that particular couple, how long can it actually take to eventually have that couple have a child?
So it varies from couple to couple, but on average, a minimum of 1 year to about 3 to 4 years, depending on the cause. Because even with the assisted reproductive medicine techniques, sometimes patients actually need multiple cycles of it before they can actually fall pregnant. So then it unfortunately also brings in the financial burden and the financial cost, which also then puts a strain on the relationships, puts a strain on the couple, can also then delay the treatment, because it can unfortunately go into the hundreds of thousands of rands for some of these fertility treatments. Wow. And not everyone has that on hand in order to fall pregnant. And sometimes people need at least 3 or 4 of that cycles before they can fall pregnant, and that can take sometimes up to 4 years.
Sure. Siphesihle, let's bring you in here because, we are hearing all the different sort of factors that are taken into account, right? The financial strain, there's physical strain, there's medical tests, and obviously there'll be emotional strain that comes with that. What are some of the biggest psychosocial or mental health issues that can be experienced by a couple that's undergoing this kind of treatment?
Often we would see women having depression, because remember, depression is loss, which essentially says the inability to have a child counts as a loss for the woman or the couple. And by default, if the challenge continues or persists, it makes the depression that much more challenging and chronic. And in those journeys, having good psychosocial support system is very important, because then it alleviates the burden of responsibility. So having a partner that supports you and having a joint discussion as a couple to say, this is what the challenge is, this is what the resolution is or lack thereof. And then as a couple, you come together to say, in the cases of us not being able to have a child, what do we want to do as a couple? So having a shared responsibility in couples greatly helps to minimize the adverse side effects of having depression and or anxiety, because then the couple is not going to be able to partner up in saying, these are the pros and these are the cons.
Yeah.
And this want to do. And in a case where there's a shared accountability and responsibility, we find that the outcome is usually better in managing the depression and or the anxiety. In cases where it's not, then we do have psychopharmacological interventions to assist whichever party is suffering from either depression, anxiety, from the challenge of not being able to have a child. In that case, a joint intervention between having been on treatment and then going for therapy is proven to have or yield bigger and faster results.
Yeah. Let's talk a little bit about the process of once you have to accept whether, okay, we won't be able to have a child here. We've tried so many ways. Dr. Esther, how do you deliver those news, and what would be the indicators on your side that, you know, we've done enough now and unfortunately there's no way forward from here?
So a number of factors are taken into consideration: the number of times the cycle has failed, or whatever factors that the patients may go through. And we also see what other avenues we can also exhaust, because there is still the option of a surrogate, so someone being able to carry the child for the couple if they are willing to also undertake that financial responsibility, etc. But there's a lot that also goes into that process. And if that has also been tried and it's also been unsuccessful, then we do counsel the patients that, look, we have tried everything that we can. There have been a few instances where patients have actually spontaneously then fallen pregnant. And the other times we do have to sit them down, counsel them and tell them that, look, we have tried everything. Let's take a break. Let's revisit this conversation or look at other options or modalities. Sometimes if you might need to use an egg from a donor egg, etc., or if you do need to consider the potential to actually go through adoption.
Yeah. And once in the different scenario where the couple gets pregnant, what's the process there? Because I'm sure it's also a fragile season for the couple.
Yes, it is. So as much as we can, it is then considered a high-risk pregnancy because of everything that we needed to undergo in order to get to this point. We want to support the pregnancy as much as we can with certain medication. Make sure that they go through some detailed scans, make sure that there's no abnormalities with the baby, and if there's an issue with the cervix. So we manage everything as we consider we think that might actually cause a potential poor outcome in the pregnancy. We still do want them to undergo psychology and therapy, just because we know that because of the frequent losses that they may have had or the struggles that they have had, it does put a strain and a burden on the pregnancy. And we find that a lot of women tend to think the worst during their pregnancy, and they actually rob themselves the opportunity to enjoy the current pregnancy. So we often have to remind them that, look, we've gotten this far, celebrate the milestone, let's push and progress up to the next one. Actually try and go shopping or have a maternity shoot, etc., just so that they can enjoy their journey through this current pregnancy and celebrate the success at the end of it.
Yeah, we have to wrap it up, Siphesihle, but really quickly, we actually got a question from one of our colleagues saying that would parents who had to go through infertility treatment and that entire process to have a child, would they then spoil that child once they have it? Is there a factor like that to consider when a couple like this finally do have a child?
Yes, that is a high probability, or we call them helicopter parents, where have a child, you're always hovering. You want to make sure the child is safe, the child is secure, and you go into extremities in the decisions you make with regards to their friends, the school they go to, the playground, and all of that, because you're trying to protect this child because you understand the struggle it took for you to actually get this child that you have. So you become a parent, which it has its pros and cons, but remember, an individual is different and multiple factors contribute to multiple outcomes later on in life. So yes, definitely parents would spend excessive amounts, but we try and tell them moderate, because remember, this is a child you're going to have to raise for a long period of time, so you're going to need all the money in future as well.
All right, Siphesihle, I think this is going to be the second part of that conversation, because I know that we didn't touch some of the points that our producer wanted to touch on, because I think we were supposed to touch these introductive themes, because they're just not light-hearted just to pass through very quickly. So thank you both for giving us those detailed understandings of that journey, because I think it's an important one. But I think the second part can be us understanding the parenting after this journey of trying to have a child, if it's a long period of time. I think that also can be another conversation for next week. Thank you so much to Siphesihle Dlamini, clinical psychologist. Thank you to Dr. Esther Olusola, gynecologist and obstetrician.